Hi there, we are going to discuss brain herniation today in this lecture. It is pretty vague and you have only to know classification and possible causes with complications. So let's start with Monroe-Kelly doctrine, which says that the brain is an encased structure within the skull, and any rise in intracranial pressure is limited. As you know, three components of the brain skull. Inside is brain, blood vessels, and of course cerebrospinal fluid. And an increase in these structures in volume will compress another one and will decrease the compliance of the skull entirely, or the whole brain structure. And there is subfalcine, transtentorial, central, tonsillar, and upward herniations. For example, in subfalcine, which involves the cingulate gyrus, and it is pushed against the falx cerebri. Transtentorial or uncal involves the medial temporal lobe, which is often squeezed by a mass under and across the tentorium. We'll see many pictures forward. Central herniation involves both temporal lobes through the tentorial notch, which pushing the structures downward. A tonsillar herniation is caused by an infratentorial mass forcing the cerebellar tonsils through the foramen magnum. An upward herniation occurs when an infratentorial mass compresses the brainstem. Etiology of brain herniation. As you know, brain herniation is a life-threatening event and needs urgent attention. And causes of herniation could be the following, like hematoma from traumatic epidural or subdural hematoma, any type of hematoma, intracranial hemorrhage, which is active and after transforming in hematoma, contusions, malignant infarction, tumors, any type of tumors, benign or malignant, which increase in size and make it compressive. Infections as well, like abscess, empyema, or hydatid cyst, as they increase in size and make compression. Hydrocephalus from increased pressure of cerebrospinal fluid. Diffuse subarachnoid hemorrhage, pneumocephalus, traumatic or postoperative, mostly occur in a postoperative period as tumor excision can lead to air accumulation or pneumocephalus and make compression of the adjacent structures. Cerebrospinal fluid over drainage, metabolic hepatic encephalopathy. Pathophysiology, brain herniation, have 5 types and include the following, like subfalcine herniation, transalar or transsphenoidal, transtentorial, uncal, central transtentorial, descending and ascending, cerebellar, tonsillar herniation, and transcalvarial. Subfalcine, as example, herniation is ipsilateral cingulate gyrus gets migrated beneath the anterior falx cerebri. So this one is falx cerebri, and you see the cingulate gyrus is going to the opponent side and make herniation. Transalar or transsphenoidal herniation have 2 subtypes, like posterior and anterior, and maybe infarction within the middle cerebral artery territory, which result from its compression within the sphenoid ridge. Here we have two images, like frontal lobe mass-like effect as you see this one, and image is distorted, and from this side is going to the central part and making compression. And on the right side to see middle cranial fossa or temporal lobe mass affect this one is temporal lobe and make compression of structures, like from this side is going to this one and make even a line of herniation is seen. So anterior or descending variant of transalar herniation, which is from compression of the supraclinoid segment of the internal carotid artery against the anterior clinoid process, leads to infarction within the territory of the anterior and middle cerebral arteries. Transtentorial ankle herniation leads to compression of the cranial nerve 3 and resulting in a constriction followed by dilatation of the ipsilateral pupil. So this one is tentorium, and herniation of the structure through this tentorium is called transtentorial ankle herniation. On the left side of the brain you see a normal-like structure, and on this one you see tissues that going downward and herniate from the compression. So many of scenarios like infarction within the temporal or occipital lobe owing to compression of the calcarean branch of the posterior cerebral artery as well, or the lateral displacement maybe for a compression of the aqueduct of Sylvius, as midbrain is further displaced and a contralateral cerebral peduncle is forced against the tentorium edge, damaging contralateral corticospinal tract. That of course will lead to paresis or paralysis ipsilateral to the mass lesion. Central herniation, it's a pathological descent of the brain stem through the incisura progresses. Venous congestion along with stretching and tearing of small perforators create diuretic hemorrhage, and a vegetative state or impending death due to damage of the important centers like respiratory and cardiac in the medulla by the herniated cerebral tonsils. As you see, the central part of the brain that pushing down the structures and compressing brainstem, pons, and medulla through the foramen magnum. And of course can appear some symptoms, and they are together and create a Cushing triad like hypertension, bradycardia, and irregular respirations. History and physical examination. We have one case like discussed here, or was early identification of pupillary asymmetry and rapid correction of the underlying pathology help limit secondary insults. Subfalcine herniation is equal with lower limb weakness owing to the infarct of the motor homunculus. Ipsilateral anisocoria with contralateral motor weakness following ankle herniation. And further progression of any of the type of herniations will lead to increase in intracranial pressure and will lead to shift of the diencephalon, leading to altered sensorium from distortion of reticulating system. The one set of downward transtentorial herniation is evident by the presence of decorticate and decerebrate posturing along with loss of brainstem reflexes, chain stroke pattern of breathing, ataxia, apnoea, and fixed pupil dilation, and even respiratory arrest in severe cases. Evaluation. Subfalcine herniation, there is an effacement of the ipsilateral horn with the displacement of septum pellucidum, followed by the progression of compression and obliteration of the basal cisterns. Along with hydrocephalus results in brain torsion. Central herniation leads to complete obliteration of perimesencephalic and perimedullary cisterns. An upward herniation leads to flattened quadrigeminal cisterns, spinning top appearance of the medulla and associated hydrocephalus. After we know some classification, we are going to management of the brain herniation, which is important. So brain trauma guidelines recommend monitoring intracranial pressure in patients with severe traumatic brain injury. Patients coming which are brought to the emergency department with Glasgow coma scale from 3 to 8 points, which is equal to coma, abnormal CT of the head from any of the origin, age over 40 years, and systolic blood pressure less than 90 millimeters of mercury, abnormal posturing. It means that the patient should be transferred to intensive care and transferred to mechanical ventilation and monitoring. Intracranial pressure threshold like 22 millimeter of mercury and up is considered abnormal and should be controlled to be at least less than 22. And cerebral perfusion pressure should be maintained from 60 to 70 in these cases to maintain vital signs of the brain. What you can do by our action is evacuation of mass lesion like hematoma, contusion, infarction, edema, or tumors that make this compression. Physiological neuroprotection like sedation, analgesication, or analgesics administration and ventilation with short, high-frequency ventilation to make a low carbon dioxide level. Cerebrospinal fluid drainage with installation of cerebrospinal fluid external drain, osmotherapy or diuretics, and of course increase the level of natrium or sodium. Hyperventilation only for short terms, hypothermia, which is mostly for maintaining normothermia and prevent fever for patients as they increase the metabolic activity of the brain. Barbiturate coma if necessary for decreasing brain activity and correlate patient with mechanical ventilation and decompressive hemicraniectomy. We have to make differential diagnosis and establish the correct one to know for certainly what is the cause of brain herniation or per stage of herniation. Post-traumatic subclinical seizures, acute hydrocephalus, tension pneumocephalus, dyselectrolytemia, meningitis, cerebrospinal fluid over-drainage syndrome, osteopetrosis, costello and posterior fossa crowding syndrome. So make sure you are making a differential diagnosis and establish the correct one. Thank you for attention. Have a great time, guys.